Now, we have heard about the new National Preventive Health Strategy. I was eagerly awaiting its publication, and then it came, as Helen said, a couple of days ago, and no mental health appeared in there. Now, I do want to urge everyone, it is a consultation document and it is open for input and submission. So I think the mental health community really needs to take some action here and put in lots and lots of submissions sort of saying, where's mental health? Economics doesn't feature very much in the strategy either. In fact, it features in this tiny little thing that I've kind of circled there where, the whole point of this preventive strategy is to potentially impact the rising economic burden of disease, and that's pretty much where any reference to economics kind of ends. So there's probably a couple of points that I might make in my own submission to this strategy. But it was good that the economic burden was highlighted, and I thought just to put that in context, and David has also told us a little bit about how economics can be used for good to really draw attention to the importance of investing in both treatment and prevention. So what is economic burden? Now, clearly it's, costs, financial costs, which are the things that most people are aware of. Now, things cost money. So we've got costs that that are borne by the health sector, hospitals, emergency departments, community-based health services, both primary care, specialist services, medications. We've got costs that could be borne in other sectors, criminal justice, education sector. They're all potential sectors that are impacted by mental health that have costs. We have productivity, and we've already heard about that. We've got productivity costs attributable to both absenteeism, missing days off work, and presenteeism, not being at work, but also importantly, participation rates. We know that some, mental health illnesses such as schizophrenia have very low participation rates. Then we've got costs which we might deem non-financial costs, but still costs nonetheless. We've got unpaid carer time, very, very important. Quality of life and burden of disease kinds of costs in inverted commas. And then I've just highlighted some of the actual costs that have come from the Productivity Commission interim report, where clearly there are the direct service provision costs of mental health care, $18 billion, productivity impacts, 10 to 18 billion, carer replacement costs, 15 billion, and then that sort of, makes up, I think it was the $42 or $43 billion that was discussed during the first session on Tuesday by, I think Cathy Chapman brought up those numbers. And then we've got this very large disability and premature death cost, which is basically putting a dollar value on the burden of disease, quality of life kinds of costs. So we're talking about, very, very large numbers. But again, mental health is not the only kind of area that has such large numbers, though we do have very large numbers. So what can be done about this economic burden? And we've already seen what can be done. We can, deliver high-quality, evidence-based care. That's one thing that can be done. And David talked about cost savings. Now, cost savings are, of course, very important, but then we've also got this other concept that I'd like to focus upon as well, which is value for money. Now, we assume that prevention will reduce costs, but not always. And if an intervention doesn't reduce costs, if it doesn't save more than what it costs, is it still worth doing? And that's a very big question. And when interventions do save money, clearly they're no-brainers, but sometimes interventions, we might have to pay something to get a health benefit or a health benefit. Is it still worth doing? And I would argue, yes, it is. Sorry, all right, so just moving on. So we have this basic economic problem of scarcity, and there's an opportunity cost to every choice. By deciding to spend our money in treatment of mental health or prevention of mental health, that means that we can't spend those dollars on something else because we've got basically limited resources available. Now, we use economic evaluation as a technique to allow us to help make decisions about what we should and shouldn't invest in, basically. And as an academic health economist, who spends a lot of time undertaking these sorts of studies, it is really to inform policymakers and decision makers as to what kinds of conditions are value for money and worth it. Now, when we talk about value for money, it is really the willingness to pay for an outcome or product, and it is a value judgment. Okay, is something worth it? Doesn't necessarily mean that it's going to save us money. It's like when we go out and buy something out in the shops, or in the open economy. It doesn't necessarily save us money because we're giving those resources up, but we're getting some value for that. So a focus on simply saving dollars means that also that there is a potentially alternative, better use of those dollars, and sometimes there may not be. So I think we just tuck that one away and just sort of and we'll press on. So economic evidence. So moving on to, are preventive interventions in mental health cost effective? And that's the age-old, question I suppose that we've got. And the answer is yes to that. But I just want to focus on a couple of our local homegrown kinds of studies. And one is a study that was actually commissioned and paid for by the National Mental Health Commission. Thank you, Christine, and the team there. And it was basically a return on investment study that my team did the modelling for. And basically, that particular study, we looked at 10 interventions that were selected for further modelling to work out what the return on investment might be of these particular interventions. And these were interventions that were selected by the Commission, really spanning the lifespan, if you like, looking at interventions both in the workplace, targeting, younger children, youth, middle age and older age as well. Now, they are not everything that you can do in the preventive space, but they were a very nice selection of the kinds of things that you could do potentially across the lifespan. So now all of these are available on the Commission's website, and I did give the link there. Now, these are the results of those studies. So every single intervention bar one, intervention one, had a positive return on investment. Now, I also need to say that we were quite conservative in our modelling of this particular of these particular interventions. We weren't optimistic in terms of how long, or the time horizon of how long the interventions would work, or how many cost savings we would expect. We were quite conservative in a lot of our assumptions around them. And these particular results that I'm showing you here don't even include the health benefits that we might expect with investing in these particular interventions. It is really the cost of the intervention, and from that we've subtracted likely cost savings to the healthcare sector, as well as likely productivity benefits as well. That's pretty much it. So we weren't overly optimistic in our economic benefits. So pretty much all of them, and they were variable in how high or how large the return on investment ratio is, but anything over one we would deem basically it saved more resources than what it cost. Oh, hang on, here we go. Now, we also, because we've done this sort of modelling in other work as well, where we haven't included productivity gains, and the reason why we did that is because in Australia, our two main health technology assessment bodies, which is the Pharmaceutical Benefits Advisory Committee and Medicare Services Advisory Committee as well, don't include productivity gains. So we thought, all right, we'll try and be similar in terms of how we might do the modelling to how our health technology assessment agencies work. And we also modelled QALYs as well separately. And what we found when we did that is that a lot of these interventions still remained dominant. That is, they still saved more resources than what they cost, even if you didn't include productivity gains. But they also, and for those that didn't, still had quite favourable cost effectiveness ratios. So taking out those productivity costs meant that they were still quite favourable cost effectiveness ratio. And a rough rule of thumb that we often use in Australia is around $50,000 per quality adjusted life year. And they all, bar the top one, fell quite, within those, value for money judgments. So all quite good to do. Now, do we have other evidence that prevention in mental health is cost effective? Well, yes, we do. And in fact, my team has just done, a recent systematic review of all the available economic evaluations for preventive interventions in mental health. It is currently under review. It's not published yet. And there are 52 studies that met the criteria for our review, 18 focusing on children and adolescents. And there were a broad range of interventions that were evaluated there, but parenting came out. 25 studies focusing on adults and 7 studies focusing on adults and carers. My final slide, the perennial question. are such interventions affordable? Now, these are some estimates that I did quickly, back of the envelope, so I don't want anyone to formally quote me yet, because we do need to do a little bit of double checking, but they're absolutely affordable. We looked at just the interventions that had been modelled in Australia, all preventive interventions using similar techniques across not only mental health but other kinds of conditions as well. And we found that if we invested in all cost-effective preventive interventions, it would be around 2% of health expenditure. The mental health interventions were 0.2%. I would argue quite affordable. That's it from me. Thank you.
Thank you very much, Cathy. That's pretty amazing, isn't it? How much money do we need to actually get preventative interventions working? Doesn't sound like that much compared to the overall mental health budget. Maybe that's something we should pick on as a particular goal that we want to make sure that governments and other policy makers are aware of. So I have one question for you, Cathy. Really interesting work highlighting the economic and social imperative for prevention. To what extent were you able to model cost effectiveness over the long term?
So this is a tricky one, isn't it? Because it's tricky over the long term because we are constrained with the evidence that we have available to us. So what we did in our modelling was we didn't actually assume that these interventions would work forever in a day. We made some assumptions around how long they may work for based on the evidence that we had available for us. We then said, well, perhaps, the effectiveness might taper off over time, and that's kind of what we modelled. If you became more optimistic in some of your modelling assumptions, the numbers would be even more attractive. So I'd say that what we did was kind of, quite conservative, but, we really do need investment in research that does allow us to do longer term follow-up of a lot of these interventions to see what, the longer term benefits really are. And looking at both things like productivity as well as, of course, the mental health gains as well.
And could I just have a quick follow-up question, which was when you showed that return on investment graph at the end, what were the interventions that were the highest return on investment? Because it was quite difficult to see and
So the winner in that one was basically it was a school from memory, intervention 8. Let me just go back and double check which one that was, which was e-health intervention for the prevention of anxiety disorders in young people. Was the most highest, the highest return on investment. And the way that we modelled that was basically that, as part of the health and wellbeing programs at school, the kids would do an online course, 6 sessions for an hour, basically. And there was some good evidence around that, reasonable evidence around that.